Vanakkam, good morning. In this video, we are going to discuss about the cardiac output. Cardiac output is the amount of blood pumped by each ventricle per minute. So normal cardiac output is the 5 liter per minute. Cardiac output is mainly dependent on the stroke volume and heart rate. So normal stroke volume is 70 ml, average 70 ml. Heart rate is average 70. So 1770 multiplied by 4900, average 5 liter per minute. So cardiac output is the amount of blood pumped by each ventricle per minute. Stroke volume is the amount of blood pumped by each ventricle per heartbeat, one heartbeat. So amount of blood pumped by each ventricle per heartbeat. That is 70 ml. Normal stroke volume is the 70 ml. Cardiac index is a cardiac output is divided by body surface area in square meter. Okay. So cardiac output is the 5 liter. Body surface area is the 1.7 meter square. So the cardiac index is normal is 3 liter per minute per meter square. So cardiac index is cardiac output is divided by the body surface area in square meter. Normal value is 3 liter per minute per meter square. N diastolic volume is amount of blood present in each ventricle at the end of the diastole. Normal N diastolic volume is 130 ml. Ejection fraction is percentage of the end diastolic volume pumped with each heartbeat. Each heartbeat, how much percentage of the blood pumped from the end diastolic volume is the ejection fraction. It is calculated by stroke volume is divided by the end diastolic volume, that is multiplied by the 100. Normal ejection fraction is the 65%. Ejection fraction is the index of the myocardial performance. When the ventricular dysfunction, ejection fraction is less than normal value. So normal is more than 65%. When the ventricular dysfunction, the ejection fraction value is decreases less than 60. End systolic volume is the blood remaining in the each ventricle at the end of the systole. So normal end systolic volume is 50 ml. The cardiac reserve is the amount of blood pumped in excess of each ventricle per minute. So normal cardiac reserve is 15 to 20 liter per minute. The cardiac reserve more helpful during the exercise and tachycardia. So that time the amount of blood is pumped in excess of each ventricle per minute. The normal cardiac reserve is 15 to 20 liter per minute. What are the factors affecting cardiac output? Cardiac output mainly depend on the stroke volume and heart rate. Stroke volume is depend on the preload. Preload is nothing but end diastolic volume. End diastolic volume is the preload, and myocardial contractility. Afterload is the resistance to the flow of the blood from the aorta. So afterload is the resistance to the cardiac output is the afterload. So stroke volume depend on the preload, that is end diastolic volume and myocardial contractility afterload. Afterload is mainly depend on the peripheral resistance and viscosity of the bloods. Heart rate mainly depend on the autonomic nervous system. Sympathetic nervous system increases the heart rate. Parasympathetic nervous system decreases the heart rate. Preload is end diastolic volume. According to the Frank-Starling's law, force of contraction is directly proportional to the initial length of the muscle fiber within the physiological limit. That means the cardiac output is directly proportional to the end diastolic volume. So cardiac output is varies with the end diastolic volume. So that is heterometric autoregulation. The length of the cardiac muscle fiber is varying. So preload is comes under the heterometric autoregulation. Preload is mainly depend on the venous return. Venous return is affected by the skeletal muscle pump. So during the skeletal muscle contraction, the blood is flow towards the right atrium. So during the skeletal muscle relaxation, prevent the flow of the blood into the opposite direction. The thoracic pump during the deep inspiration, the intrapleural pressure is more negative. That is favor for the increases the venous return. And during the abdominal pump, during the inspiration, intra-abdominal pressure is increases. That is helpful for the increases the venous return. The increased extracellular fluid volume increases the cardiac end diastolic volume. Decrease ECF volume decreases the end diastolic volume. Sympathetic activity increases the venoconstriction, that is favor for the increases the venous return. And atrial pump activity. Atrial pump activity is actively fill the ventricle, that is contribute the 20% of the ventricular filling. The remaining 80% of the ventricular filling is passive, occur passively during the ventricular diastole. During the exercise tachycardia, atrial pump activity is important for the end diastolic volume. And ventricular compliance. Flexibility of the ventricular muscle is important for the end diastolic volume. Conditions like pericardial effusion, cardiac tamponade, ventricular compliance is affected, and end diastolic volume will decreases. Myocardial contractility. Factors that increases the myocardial contractility is the positive inotropic. Factors that decreases the myocardial contractility is the negative inotropic. Myocardial contractility mainly depend on the ventricular muscle mass. In the myocardial infarction, the ventricular muscle mass is damaged, so myocardial contractility is decreases. In the athletes, regular athletes, they are having the more ventricular muscle mass, physiological hypertrophy occur, so it can more myocardial contractility. So the more muscle mass in the athlete, more ventricular muscle mass in the athlete, so it produces the increases the myocardial contractility. The autonomic nervous system, the ventricular mass is innervated by the sympathetic nervous system. So sympathetic nervous system is increases the myocardial contractility, and the parasympathetic nervous system sparsely innervated in the ventricles. Hormones. Catecholamines act on the beta 2 receptors. It increases the cyclic AMP. It increases the myocardial contractility. Acetylcholine act on the muscarinic receptor. It decreases the myocardial contractility. Glucagon increases the myocardial contractility. Insulin also increases the myocardial contractility. Thyroxine increases the myocardial contractility through act on the beta 1 receptors. So increases the sensitivity of the catecholamine to the beta 1 receptors. This also increases the myosin ATPase activity in the cardiac muscle. This also helpful for the myocardial contractility. And chemicals like xanthines such as caffeine, theophylline increases the myocardial contractility by increases the cyclic AMP. And inhibiting factors are hypercapnia, increases the carbon dioxide level, decreases the hypoxia, acidosis, anesthetics, general anesthetics, drugs, and toxins. These are the decreases the myocardial contractility. And the drugs, digitalis increases the myocardial contractility by inhibiting the sodium potassium pump. So inside the myocardial cell, sodium concentration is more. So due to the increased sodium concentration inside the cell, and the sodium calcium exchanger is not acting, so calcium level inside the myocardium is more. It increases the myocardial contractility. Quinidine, procainamide, barbiturate inhibit the myocardial contractility. The peripheral resistance is considered as the afterload. The peripheral resistance comes under the homometric regulation of the cardiac output. Here no change in the ventricle muscle fiber length. The homometric regulation by the peripheral resistance is explained by the Andreff effect. Vessel diameter and viscosity of the blood both are affecting the peripheral resistance. When the vessel diameter is increases, cardiac output is increases. When the vessel diameter decreases, cardiac output is decreases. When the viscosity of the blood increases, conditions like polycythemia, cardiac output is decreases. When the viscosity of the blood decreases in the anemic condition, cardiac output is increases. Factors affecting heart rate. Parasympathetic stimulation, that means vagal stimulation, decreases the heart rate. So cardiac output is decreases. Sympathetic stimulation increases the heart rate. So cardiac output is increases. Regulation of cardiac output. It has two types: intrinsic regulation and extrinsic regulation. Intrinsic regulation is otherwise called as the auto-regulation. The Frank-Starling mechanism comes under the intrinsic regulation. Depending on the end diastolic volume, cardiac output is changed. This mechanism comes under the heterometric regulation. Depending on the change in the length of the ventricular muscle, cardiac output is changed. Another intrinsic regulation is the rate-induced regulations. It's mainly dependent on the entry of the calcium ions, force frequency regulations. So dependent on the entry of the calcium ions during the flatty phase of the action potential, it increases the number of the action potentials, and the space between the successive beat also decreases, so that increases the heart rate. So this is also comes under the intrinsic regulation. Extrinsic regulations are afterload, and this is come under the homometric regulation. The homometric regulation, so no change in the length of the ventricular muscles. No, homeometric regulation depend on the afterload, especially variable resistance is explained by the Andruff effects. And neural control, sympathetic stimulation increases the myocardial contractility and increases the heart rate, increases the venous return. And hormones like catecholamines, thyroxine, insulin, growth hormone increases the heart rate. And the chemicals, carbon dioxide and acidosis depresses the myocardial contractility, decreases the cardiac outputs. These are comes under the extrinsic regulation. Thank you for watching this video. If you like this video, press the like button, share your friends. Those who are not subscribed this channel, please subscribe. These videos briefly discuss the physiology topics. You must read the physiology textbooks. Thank you once again.